Hi, I'm Deborah Sims. I'm a CLL patient from Melbourne, Australia. I'm here at the American Society of Hematology conference in San Diego on behalf of Leukemia Care UK, interviewing doctors who've just come out of sessions for patients primarily across Europe. And I'm with Professor Peter Hillmen from St James Hospital in Leeds.
Hi, Deborah.
Hello again. And you're speaking this afternoon at the conference.
Yep.
What will you be talking about?
So we're talking about the UK trials, so the TAP programs. There's two trials Andy Rush and myself will be presenting in the oral sessions. So one of which is really looking at targeted therapy in relapsed patients with CLL. So looking at ibrutinib and how we can best use that drug, and also the combination of ibrutinib with venetoclax to see if we can drive the disease into a remission where we can't detect it, so an MRD negative remission, which is, if we're going to stop therapy and at least have times off treatment, is probably the most effective way of doing it.
An undetectable disease is a big feature here at the conference. I've just come out of the Future of CLL Treatment session. And why is undetectable disease the end goal at the moment?
Yeah, I think it really depends on the patient. So some patients, and certainly in frontline with ibrutinib, for example, we would not expect to eradicate disease. And actually the outcome from 3 large trials here is that those patients do extremely well. So in frontline, that approach certainly controls the disease for many years and for many patients, and is better than chemoimmunotherapy. The question, of course, then is, do you really want to be on therapy for a prolonged period of time? And would it be more effective to get to a place where you could stop treatment? And the only way we're going to do that is by getting the disease to a level where we can't see it, and then stop, and then follow patients to see what happens. And that's been our approach, certainly in the UK group and several other groups. So MRD, if our aim of therapy is to stop treatment, and I guess in the future to cure CLL, then we have to get rid of detectable disease.
And combination therapy is obviously hugely important. We're hearing about different combinations here. Some more trial data is obviously being published. I think there's over 1,000 CLL abstracts being published here, which is very overwhelming. Which sort of combinations, in particular the MURANO trial, there's some obviously interesting data that you're involved with. What should patients be looking out for?
Yes, so I think the MURANO trial is the first phase 3 trial randomised trial with venetoclax, and that combines venetoclax with rituximab. So we showed previously that combination was better than chemotherapy in relapsed disease, but also that most patients with the combination achieve an MRD negative, a deep remission. And actually those patients can stop, when they stop treatment at 2 years, most of them remain in remission, and we have data at this meeting a year later, and most of those patients who are negative, only 2 of 83 have actually progressed who were MRD negative when they stopped. So I think that's the first promising combination data. And we've also got some data looking at combinations with obinutuzumab and also with ibrutinib and venetoclax. So our targeted treatments, which, I mean, the importance of those different combinations is if you attack the leukemia cell in different ways, the therapies add together, and that hopefully and seems to improve the depth of remission, and therefore hopefully the time off treatment.
And obviously from a UK perspective and quite a few health systems perspective, the idea that we can stop treatment and not have that cost and be able to justify an intense period of treatment must be advantageous.
I think there are lots of reasons why stopping therapy is a good thing. I mean, first of all, side effects. So even on targeted treatment have some side effects, and I'm sure patients prefer not to be on treatment than on treatment. If we're thinking about the evolution of resistance, so when people fail these targeted treatments, that happens when you're on treatment. So if you're off treatment, if you then relapse, the patient relapses, they're likely to still be sensitive to the therapy they had before. Whereas if they're relapse on treatment, then they're not going to be. And then, of course, as you mentioned, the cost issue is important. It's not, I think, primarily the most important issue, but it's certainly an important part of our trials.
Thank you. Thank you. Enjoy the rest of the conference.
Thank you.
Thanks.